All right, thanks, Laura. So it's a real pleasure to welcome Dr. Rebecca DeBoer to speak to us today at our Global Oncology rounds. Um, Becky is an assistant clinical professor in hematology at UCSF and attending medical oncologist at Zuckerberg San Francisco General Hospital. And I had the chance of connecting with Becky over email over some shared research interests. And so it's really nice to have the chance to meet over Zoom and to share some ideas and have a conversation. Becky received a BA in human biology from Stanford and a joint MD, MA in medical humanities and bioethics from Northwestern. And her master's thesis focused on the ethics of global cancer care and control. She completed internal medicine residency at University of Chicago and a fellowship at McLean Center for Clinical Medical Ethics. After residency, she worked in oncology in rural Rwanda with Partners in Health. And in fact, she knows Fidel, which is really, really cool. And she's completed her oncology fellowship at UCSF. And her current research focuses on resource allocation, patient clinical communication, and clinical guideline implementation in Rwanda, in Tanzania, and the public safety net in San Francisco. And today she'll be speaking about improving patient prioritization for limited radiotherapy resources and lessons learned from a mixed methods study in Rwanda. So I'll hand it over to you, Becky.
Okay, great. Thank you. Can you see my screen?
Yes.
Okay, great. Thank you, Tim, for that introduction and for the invitation to speak to this group. I'm really excited. I'm familiar with your work, many of the folks in this group through papers and Twitter and podcasts. So it's cool to be here. I have no conflicts of interest. I do think it's important to acknowledge positionality, especially in global health. And so I am American, I identify as white, and I use she and her pronouns. And I'm a medical oncologist, as you just heard. I was trained in the US. I'm also trained in bioethics. I've had the privilege of having a few very important formative experiences in global oncology. The most significant was working with Partners in Health as a clinician in Rwanda from 2015 to 2016, alongside Fidel, who I think many of you probably know. And then I've had shorter term experiences in other places, and I'm currently collaborating with research partners in Rwanda and Tanzania. And so that is the lens with which I approach this work. So today I'll talk to you about a mixed method study that we conducted in Rwanda that was focused on improving the process for prioritizing limited radiotherapy resources. This was a big collaborative project co-led by my colleague, Dr. Cyprian Shirambere, who's the director of oncology at Partners in Health. It's a big project, it's a lot to cover. I'm going to sort of give you the overall sort of overview and then do a deeper dive into a few of the aspects, particularly our qualitative data and the process for guideline development. So first, a few words of background because the context here is very relevant. I think this audience knows well that radiotherapy is an essential component of effective cancer treatment, and it's estimated that at least half of all cancer patients globally would benefit from radiotherapy for curative treatment, local disease control, and palliation of symptoms. This is probably an underestimate in low resource settings. The need for radiotherapy can be quantified by the metric radiotherapy utilization rate, or RTU, which is the proportion of new cases of cancer with an indication for radiotherapy based on guidelines. And the chart on the right shows the RTU for several common cancers. In the first column, you see the RTU is very high for breast cancer, cervical cancer, head and neck cancer, et cetera. And in the columns on the right, you can see that the benefit of radiotherapy in terms of local disease control and overall survival, with highest for cervical cancer and head and neck cancer. So again, this is sort of a way of thinking quantitatively about the benefits of radiotherapy. Yet, despite tremendous benefits, we know that there is a severe shortage of radiotherapy resources worldwide. The situation is getting better in many places, but still in 2020, about half of African countries had external beam radiotherapy in country. And in Eastern, Central, and Western Africa, less than 10% of all cancer cases that required radiotherapy were covered by operational capacity. So this obviously is a situation where in many places, the demand for radiotherapy outstrips supply. And what this looks like on the ground is that by definition, many patients who could benefit for curative or palliative intent are untreated. There are significant delays to treatment initiation in many places, which impacts outcomes. And places that do have functional radiotherapy capacity are very vulnerable to machine breakdowns, staff shortages, and other system barriers. And without deliberate systems for prioritizing this limited resource, access is often determined by ability to pay, for example, in the private sector, or social privilege, or first come, first served basis, and other morally arbitrary factors. And so there's a need for pragmatic prioritization frameworks that can be readily applied in low resource settings. And before we go on to talk about our specific context for this project, just a few slides of some ethics concepts that I think are relevant. So when it comes to distributing scarce resources, the terms rationing and resource allocation are often used interchangeably, but in bioethics, we actually distinguish between them. So the term rationing refers to resource distribution under conditions of absolute scarcity. So classic examples are distributing ICU beds or vaccines in a pandemic, as we're now well aware of, or organs for transplantation, or dialysis units, et cetera. In contrast, resource allocation refers to resource distribution under relative scarcity. And this typically comes down to budgets. So how much funding do we allocate toward prevention, for example, versus treatment in a given healthcare budget? And priority setting is an umbrella term that encompasses both of these concepts. And I think it's worth mentioning that rationing typically has a negative connotation and is used by opponents of healthcare priority setting. Resource allocation is more neutral, and priority setting can even have a positive connotation. And I think it's also useful to think about some dimensions of priority setting. So priority setting can be explicit. So, we can codify resource prioritization schemes into insurance coverage policies or guidelines, or it can be implicit. So, left to default market forces or informal ad hoc circumstances. And priority setting can also occur at different levels of the healthcare system. So at the micro level of patient care, the meso level of a hospital or insurance health plan, and at the macro level. So, governments need to decide how much to allocate towards healthcare versus other competing needs. And then finally, another key concept that I think is really important in any conversation about resource allocation or rationing, especially in global health, this idea of socialization for scarcity, which is the underlying assumption that resources are scarce and will always be scarce, which has really been a dominant paradigm in global health. And I think it's really important to recognize that, in fact, resources in this world are abundant and greater than they ever have been. And the photo on the right is a reminder that after the Cathedral of Notre Dame burned down in 2019, 1 billion euros were raised in just 2 days. And so the idea is, as we talk about optimizing the use of a tiny resource pie, we also have to think about expanding the size of that pie and expanding access to radiotherapy, for example. So with those key concepts, I'll sort of dive into our on the ground rationing situation at Butaro Hospital. So I'll first introduce you to Butaro Hospital. Some people may be familiar. Butaro Hospital is a district hospital in rural Rwanda. Rwanda, of course, is a beautiful small country in East Africa that suffered a tragic genocide in 1994, and since that time has really had a remarkable recovery led by President Kagame that has included, among many things, an unprecedented development of social services, including the healthcare sector. Partners in Health is a human rights-based NGO that began working in Rwanda in around 2007. And in 2012, the Ministry of Health, in collaboration with Partners in Health, opened the first cancer treatment center in Rwanda at Butaro Hospital, this rural district hospital in the northern part of the country. And the mission was to develop a model of cancer care that is effective in low resource settings and accessible for poor and rural populations. So then, and to this day, Butaro provides basic cancer care services across the cancer care continuum, from pathologic diagnosis to basic radiology, general surgeries, and chemotherapy. Actually, the nurses are trained to mix and administer chemotherapy. And physicians deliver care through a task shifting model. So to this day, there are no oncologists who are permanently based at Butaro, but so the care is delivered by internists, pediatricians, GPs, in close collaboration with specialists in Kigali, as well as advisors that are based in the US. We have weekly case conference calls and frequent emails. Palliative care and socioeconomic support are also provided. And so in 2012, when Butaro first opened, there was no radiotherapy machine in the country. And Partners in Health established an agreement with the Uganda Cancer Center in Kampala for 10 patients per month to be referred for radiotherapy on their cobalt machine. And initially, for the first several years of the program, this was enough for most patients with cervical cancer and head and neck cancers that required radiotherapy for cure to be sent. But as patient volumes grew over the years, the need increased, and by 2015, the organization was able to expand the budget and pay for more patients per month to go to Kampala. And these patients, it's a 12-hour bus ride. They stayed in Kampala usually for about 6 weeks. A nurse accompanied them, and then they came back home. Unfortunately, in 2016, the machine in Uganda broke down beyond repair. It was a big tragic event that made international news. We had several patients who were in the middle of their treatment course, and many more on deck. And so the Partners in Health leaders sort of scrambled to find a solution, and ultimately formed an agreement with Nairobi Hospital, which is a private hospital in Kenya that has a couple of linear accelerator machines. And we began sending patients there. And it was more expensive. It was about almost twice the cost per patient for radiotherapy. Plus, they had to fly to Kenya, et cetera. So we were able to send fewer patients per month. Initially 5, and then we were able to sort of increase over time. In 2019, very happily, Rwanda opened the first radiotherapy unit in the country at Rwanda Military Hospital, which, for those of you who know Dr. Fidel, that is where he works. And so Partners in Health began sending curable patients who need radiotherapy to Rwanda Military Hospital. And the project I'll be talking to you about today sort of originated before the opening of the Radiotherapy Center in Kigali. And so we'll talk about sort of how that has evolved at the end. So this slide is just to make the point that a lot of patients at Butaro have cancers that have high RTUs, or in other words, cancers that could benefit from radiotherapy. So 4 of the 5 most common adult cancers: breast, cervical cancer, head and neck cancer, and rectal cancer. And when we sort of go through and crunch the numbers, we calculated that using conservative estimates, about 58 patients per month could benefit from radiotherapy. And yet for several years, we were able to send about 10 patients per month. So clearly this is a situation where demand outstrips supply. From a clinician perspective on the ground, we saw patients in clinic. We determined whether they had an indication for radiotherapy. We were sort of from the beginning limiting our spots to patients who were curable and required radiotherapy for cure. We added those patients to a waiting list, and then every time it was time to send a new cohort, we would meet and select patients from the list, and they'd come back and we'd get them organized and then make arrangements for them to travel. And like I mentioned, initially, we were able to send most patients who required radiotherapy for cure. And so there was sort of this underlying value that we were trying to maximize cure. And in the first few years, the volumes grew, and we realized, and I kind of led this effort to create some actual guidelines and sort of formalize our process. And so in 2016, we developed preliminary guidelines, and we basically sat down with our the clinicians, the leaders, and our clinical advisors, and made some back of the envelope estimations about the chance of cure in different disease groups. And this was a really important initial effort. It solved the immediate problem of clinicians, really struggling to make these decisions. But everybody sort of felt uneasy and felt like, okay, we need to go back and actually look at the data. And then there were other unresolved issues, like what about benefits other than cure? We knew that there were other principles that were relevant that were not accounted for by these guidelines. There were a lot of implementation issues, and this sort of overarching cloud of the moral distress associated with these decisions. And meanwhile, the waiting list grew, especially after the switch from Kampala to Nairobi. There was a huge backlog of patients. And this is a screenshot just to give you an idea of what the waiting list looked like. It was very long. And so that was sort of the context that gave rise to this project. So in 2017, recognizing that we were dealing with this very explicit rationing dilemma, the director of Partners in Health in Rwanda suggested that we do sort of a rigorous analysis and improvement project, and we received a grant from the Greenwall Foundation, which funds ethics research, for a project that has an overall goal of evaluating and optimizing the decisions about who will receive radiotherapy and who will not. The project had 3 aims. The first aim was to describe the process at Butaro using quantitative and qualitative methods. So we actually did a big clinical data collection looking at the referral patterns and patient outcomes. We did a qualitative study, which we'll talk about more today. Aim 2 was to focus on the procedure of decision making. And then aim 3 was to go back and revise those guidelines that I showed you using a more rigorous application of data. So I highlighted the 2 aspects I'm going to be talking about in more depth today. And I think an important role of qualitative research is to give voice to people who, have a lot of expertise because they're in the trenches, but might not always have a platform. And so that's why the qualitative part of the study, I think, is very important. It was a qualitative interview study with 22 participants who were, about half of them were oncology physicians, and then the next biggest category was program leaders, and then nurses and oncology advisors from the US. Because of the sort of international collaboration, about half of the participants were Rwandan or East African, and the other half were American or European. So the interviews focused on sort of the general experience of radiotherapy priority setting and decision making, and really honed in on what factors are considered, what values underpin decisions, what procedures are in place for priority setting, what kind of impact does this experience have on the participants, and what are their suggestions for improvement? What can we learn, and what do they recommend moving forward? And we collected a lot of data and ultimately categorized it into sort of 3 big buckets. The first is the ethical principles and values that come up when clinicians and advisors and program leaders are making priority setting decisions. The procedural aspects, so both at the program level and at the individual patient level, and then moral distress. And so I'll sort of go through and give you a sense of the results in each category. This is a chart of all of the factors that came up in our interviews. The ones with asterisks are things we actually asked about, and everything else came up. The driving factor for patient prioritization was curability, and really trying to send patients with the highest chances of cure who required radiotherapy. And there are many other clinical factors that related to that. But other benefits, including palliative benefits, were also very important and came up a lot. Non-clinical factors as well. So nationality, social value, and socioeconomic status were things we asked about. Age, time spent on the waiting list, and other non-clinical factors came up a lot. And so I'll go through some examples here so you get a sense for the data. And for the bioethics buffs out there, I put the ethical principles at the bottom, but I think I won't go through them in the interest of time to get to some of the more clinical aspects. As I said, curability was really upheld as the appropriate primary driver of prioritization. As this doctor says, a high chance of curability always trumps other things. Several Rwandan participants drew a link between curability and ability to later participate in society and resume functioning in society. Yet there, were many principles that came into conflict with curability, and this came up in many different ways. So, for example, the tension between curability and age. As this advisor says, if you have somebody who's 90 and somebody who's 20, the benefit of curing a 20-year-old is more substantial because they have many more years of life ahead of them. And I think that scales down. So this idea of not just trying to maximize lives saved, but actually to maximize life years saved as a function of age. And in addition to this sort of utilitarian life years idea, several participants talked about the value of living through life's stages, which is also called the life cycle principle. And so as in this quote, you'll see, you might have a 45-year-old patient with cervical cancer who's had children, has married. She might be more curable, but you have a child who can get 5 more years. And so you can sort of hear the tension in that participant's view. The tension between curative benefit and palliative benefit came up a lot, I think, especially for clinicians describing the role of palliation to alleviate suffering of the person in front of you. A lot of clinicians talked about the human right to pain relief and death with dignity. And the issue of waiting time came up a lot also. The idea that if you're always prioritizing curability, you're going to send new patients who have earlier stage disease, while patients on the list might, be waiting and their disease might progress. And, this came up a lot, especially from the clinicians. And then when it comes to social value, people were sharply divided, actually. About half of the participants felt strongly that social value should be considered. For example, this doctor who says, I'll be honest, if I have a patient who's a single man, heavy drinker, heavy smoker, early stage and has a chance of cure, or I would choose a mother with 5 children, less of a chance of cure over him. The other half of participants felt very strongly that social value should not be considered. So, for example, this doctor says, making calls about somebody's value as a person feels really wrong, really unethical. There's so much room for error. The role of nationality was also sort of a divisive. So for context, Butaro sees many patients from neighboring countries like the Congo and Burundi. And for other types of cancer care, for chemo and supportive care, with support from Partners in Health, all patients are treated regardless of nationality. However, for radiotherapy, especially after the switch to Nairobi, the funding support was limited to Rwandan patients. And about half of participants upheld this practice and felt like, the Rwandan Ministry of Health has a primary obligation to its people. And the, primary mission of Partners in Health is to accompany the government and accompany the Ministry of Health. And so felt like it was reasonable and indeed ethical to prioritize Rwandans. In contrast, about half of participants felt that nationality should not be considered, sort of appealing to this other interpretation of Partners in Health's mission to provide a human right to health for all, and sort of discounting the moral significance of national borders. So you can see that there are many different ethical principles and values that came up, and indeed in ethics, this is sort of a common situation where reasonable people disagree about which principles should drive resource allocation and healthcare rationing. And in ethics, there's been a shift from focusing on, establishing normative principles to agreeing on the procedures for decision making. The most prominent example of this procedural approach is called accountability for reasonableness. And so this was sort of initially advanced by Norman Daniels. And I think to this day is still sort of the dominant procedural approach that's out there. It includes 4 criteria for fair procedure for priority setting, which are transparency, relevance, which means the criteria used for decision making should be relevant to stakeholders, revisability, or the ability to appeal decisions, and enforcement. And so, for our project, acknowledging that there are many different principles that could lead to different decisions, we also focused on our actual procedure for decision making. And so our research questions were to understand the elements of procedural fairness that are important to the people in our group, to assess the feasibility of implementing fair procedure, especially in a low resource context, and figuring out how to improve upon the processes that are already in place. So thinking about procedure, in our setting, the priority setting procedure really took two different forms. The first was sort of on the program level, coming up with our guidelines, which reflected underlying principles. And then at the patient level, of course, the actual ongoing selection of individual patients for radiotherapy. And so in our qualitative study, we collected data and to try to figure out, okay, what can we learn about the procedural aspects of the guidelines and the selection meetings. So when the guidelines, it was very clear that people felt like guidelines were necessary to facilitate objectivity. And other facilitators of fair procedure were transferring decision-making from individual clinicians to a team. They felt that guidelines mitigated the emotional burden of the decisions to some extent, but noted several barriers and shortcomings. So, the guidelines that we had come up with preliminarily really needed to be revised with more rigorous analysis that came up in our data. There were several other morally relevant factors that were not incorporated into guidelines based solely on curability. And then this practical challenge of trying to include, local cultural values came up a lot. And obviously, local cultural values are not a monolithic thing, but there was, suggestion that it's really important to understand the values of the community that is affected by these decisions. At the patient level, in these recurring selection meetings, the participants described reaching decisions through consensus. There was never any sort of voting system or lottery. Advisors were consulted as needed. And over time, things did shift to what was felt to be more fair procedure. So, shifting from individual clinicians making decisions to a group, stricter adherence to the guidelines, et cetera. But there are many barriers noted. So guidelines are helpful, but if you have one spot and a few people in the same category, they can't tell you what to do. There's also potential for bias that came up, practical realities of, for example, delays in getting CT scans for staging. And then logistical barriers. So a lot of patients, even if you had the perfect prioritization system, whether or not they get radiation might come down to logistical factors, socioeconomic barriers, like not being able to get childcare or not being able to reach people by phone. And participants offered several suggestions. Focused on sort of the procedural aspects. So coming up with a multi-principle allocation system, for example, that did incorporate multiple different principles. They came up with suggestions for improving the selection meetings. There were interesting views on stakeholder engagement, but I would say most people did not favor involving patients or patient advocates in the decision making. And the feeling about transparency was generally that the process and the underlying principles for decision making should be transparent, but there was a lot of concern that actually posting the guidelines publicly could cause more harm than good. The third big category of our qualitative data was the related to the moral experience of priority setting. The definition of moral distress is that it's when somebody is unable to act in accord with their ethical values due to external constraints, and then that results in negative emotions. And it's moral distress is a root cause of burnout, which, as we know, is highly prevalent among oncology clinicians. Our participants identified both sources of both moral distress and strength and resilience at 3 different levels. The first level was sort of the program level. So, the tension between the mission of Butaro and the ideals of the program and the reality of resource constraints. I'll go through this quickly. At the patient level, they also described significant moral distress in the act of implementing constraints in patient care. So this term "playing God" came up a lot in these interviews. And then finally, not just implementing constraints into care, but actually talking to patients about resource constraints, and finding the words really affected clinicians. And they suggested many strategies and recommendations at each of these 3 levels for mitigating moral distress. And I won't go through all of them, but basically at the program level, people found that having a mission-driven purpose of providing cancer care for people who would otherwise not be able to access it, developing innovative models, and advocating for expanded resources was a source of strength. At the patient level, again, having objective guidelines and collecting local data, and really sort of honing the procedural aspects was helped mitigate moral distress. And then when it comes to communication, participants suggested communication skills training, team debriefs, and counseling and things like that. So I'm going to switch gears and talk about the revision of our guidelines, which were informed by all of these qualitative data. So as this group knows, clinical metrics are very useful for priority setting because they allow objective comparison of the value of resources. So, we use these for allocating solid organs or triaging ventilators. And in oncology, the ASCO value framework and the ESMO magnitude of clinical benefit scale are examples of attempts to quantify benefit of different therapies so that we can prioritize them. There have been several different approaches to radiotherapy priority setting that I think this group knows well. So at the macro level, there have been healthcare technology assessments for LMICs, low and middle income countries, as well as high income countries. Several high income countries have also published, or people from those countries have published prioritization systems for long waiting lines. And then CCOR, which this is how I learned about Tim Hanna, has published estimates of 5-year local control and overall survival benefits for broad categories of cancers and also for indications within cancers. So our goal was to take what is known and translate it into a sort of pragmatic tool that can be used for decision making across heterogeneous categories, sort of at the bedside. And our process was to first do a literature review, and second, we held a consultation alongside an ICEC meeting in DC, where we met with experts who generously donated their time to review the results of our literature review. And then we brought the the recommendations of the experts and the results of our review back to the team on the ground, and incorporated the qualitative data to come up with final guidelines. So I'm going to just sort of give you a sense for what this looked like. The way we thought about the guidelines was, again, we were prioritizing the survival benefit of radiotherapy. And we conceptualized that as the absolute incremental overall survival benefit. So we calculated that by calculating the difference between, for example, 5-year overall survival for a particular disease category with radiotherapy minus survival without radiotherapy. So, for example, for stage 2B cervical cancer, if 5-year overall survival with chemoradiotherapy is 66%, and without is 0%, the absolute benefit is 66%, the incremental benefit. But for stage 3 breast cancer, that is, high T stage, node positive, hormone receptor positive, can be treated with surgery as well. If the 15-year overall survival benefit is 44% with radiotherapy, 33% without, that's an incremental benefit of 11%. So we basically attempted to do this calculation for many disease categories. This is a very busy slide, but I just want to give you a sense for what this looked like. We created a worksheet with each component of this calculation, tried to find the best literature available to perform the calculation, and then ended up with the incremental benefit for these subcategories. We also incorporated qualitative data to make revisions to those initial guidelines I showed you earlier, such as prioritizing pediatric categories. I didn't mention this, but one thing that came out of our qualitative data is that regardless of chance of cure or incremental benefit, consistently children who had an indication for radiotherapy were prioritized. And so that was something that people felt strongly about. We removed age cutoffs, we removed HIV status and some other things, and then came up with these guidelines, which sort of clustered categories that had similar incremental benefits into priority groups. And you can see here, like I said, the pediatric patients were prioritized first, and then diseases where that are treated with definitive chemoradiotherapy and had high cure rates were sort of at the top, and then progressively higher risk categories as we go down, and diseases that are treated with surgery and radiotherapy has an adjuvant role are towards the bottom. So these were our guidelines. We implemented them. There were a lot of challenges that came up with this process, and I'm not going to go through this table in detail, but I just want to give you a sense for, the sort of type of challenges and complexity that we encountered trying to do this. We categorized them into methodological challenges. So, within our framework, there were a lot of areas where data were missing, or the type of evidence was really different across different disease types, et cetera. And then, even if we had a perfect methodology, there were shortcomings of this approach. So, we were focusing on survival benefit, but we know that radiotherapy has critical benefits, other types of benefits like palliation or organ preservation. And 5-year overall survival is not the same as cure rate. Cure might rely on salvage therapies, for example, which may or may not be available. And then even if we had a perfect methodology and we decided this was the best approach, there are a lot of implementation barriers when it comes to actually implementing these types of guidelines. So, and then one of the good challenges is that resource availability is very dynamic. So the Radiotherapy Center at Rwanda Military Hospital was established, I think, 2018 and officially opened in 2019. You can see Dr. Fidel in this picture. And this was wonderful because our access to radiotherapy expanded significantly. But there are still limitations related to machine breakdowns, staffing shortages, insurance coverage, and other things. And so our sort of next steps are to try to figure out, okay, with the new situation, and we're still waiting for brachytherapy to be installed, et cetera. How do we revise our prioritization guidelines given expanded access, but still the need to prioritize? So our conclusions from this project were that quantitative and qualitative data can inform a deliberate approach to priority setting, that ongoing examination of real world data on treatment patterns and outcomes is critical. I didn't go through that data, but that I think is really important to understand how our patients actually do, and how we should change our guidelines based on that. It's critical to address moral distress, and also critical to continue to advocate for expanded resources. And then finally, we just a note, in March 2020, as COVID was initially taking off, and you may have experienced the same thing, but in San Francisco, we were preparing to prioritize cancer care locally. At my hospital, which is a public safety net hospital, we suspended breast surgery for a couple of months and temporized patients with hormone therapy, et cetera. And so we found ourselves really using these lessons about resource allocation at home, and came up with 6 lessons learned, which are that a utilitarian approach to maximizing survival benefit should generally guide decision making, but there are many conflicting principles, and that it's really important to establish fair procedures for decision making in the setting of conflicting principles. It's also critical to implement safeguards to protect vulnerable people and try to curb widening disparities. It's also important to be intentional about communicating with patients and families about priority setting. And finally, critical to address the moral distress that comes with resource allocation and rationing, especially at the bedside. So that is it. I want to acknowledge my co-PI, Dr. Cyprian Sharonberry, and a huge team of collaborators, and the Greenwell Foundation for funding this work. And that's my email address. I'm happy to take questions now or by email.
Thanks, Becky. Yeah, I one thing I don't like about Zoom is we just can't hear the rounds of applause quite the same. But that was fantastic, and really, I mean, well set up and very understandable. And it's amazing the principled approach that the center took, and all the important lessons learned that came out of it. I'll just open it up for others who have questions. I see, Scott, you already have a question, so go ahead.
So first of all, thanks so much, Rebecca, for an outstanding talk, and congratulations on doing such important work. I was talking to Laura, our program lead, this morning about doing qualitative research, especially around topics in bioethics, and that's challenging in the best of times. And in a low resource setting, I'm sure it was even more more challenging. So congratulations on doing really important work and having such a big impact on helping people, apply ethics to real problems in the real world. So congratulations. I have a question for you because I'm a big fan of Norman Daniels and accountability for reasonableness. And we've actually used it as a core framework for our national drug funding body. And one of the things that was interesting when you're discussing the principles was the fact that the discussion around not wanting to include patients or patient advocates. Because having been involved in drug funding for a couple decades in Canada, and the importance in accountability for reasonableness around who's making the decisions in terms of the relevance principle and how that enhances the legitimacy of the process. For me, including patients and patient advocates in our national body was one of the major advances forward, because I think until that point, it didn't really, I think it actually was a major detractor from the legitimacy of the process. So I'm interested in the Rwandan context, why that was the case, and how that reflects on some of the principles of accountability for reasonableness.
Yeah, thanks for that question. I thought that aspect was really interesting also. One thing I learned a lot about accountability for reasonableness doing this project. And one of the things I realized is that the framework really assumes sort of a, the context of democracy and ideals of democracy, and and those ideals are culturally embedded and embedded in sort of a socio-political context. And when I first was writing the proposal for this project, my sort of American advisors were asking me, well, are you going to interview patients? And the practical reason initially was, okay, it would sort of add a layer of complexity to this research project that I wasn't ready for. And we sort of said, well, maybe we would do that at a later date. And then when we asked our participants in our qualitative interviews about, engaging patients, engaging patient advocates, the common response was, it is important to engage patients and patient advocates sort of in general. But when it comes to, and I think that people would be supportive of, my participants would support like a sort of general discussion about the principles that should guide radiotherapy. But it was felt that the, involving advocates or representatives in actual, decision making and guideline development was sort of, people wouldn't understand it, and too technically hard and stuff like that, which I think is up for debate, and we could challenge it and could try to explore that direction further. The transparency was, I think, the other interesting aspect. Transparency seems so obvious to coming from, I think, American or Canadian context, that's like, obviously we should be striving for transparency. Not that we have transparency in a lot of priority setting, at least in our system, but the common reaction among our participants was that, yes, transparency is important, but it's not the most important. And protecting people from harm and not causing conflict and not making people angry or crazy when they see that guideline on the wall and they're number 8, that's more important. And so I think there's a lot more, I think, that could be explored there, but it did make me realize how culturally embedded the accountability for reasonableness is.
Right. No, thank you. Very interesting. Yeah, the transparency was also another interesting aspect. Thanks very much again.
Yeah.
I also do just see, before we wrap up, there's a question in the chat from Andy, which says, does the Cancer Center have the full complement of planning technology, CT simulator, and treatment planning system?
The So that's a good question for Fidel. I'm assuming you're talking about the center in Kigali. And the answer, as far as I know, is yes, there's CT simulation. I'm not sure what kind of planning systems are available. I do know that in Uganda, that it was, initially when we first were planning this project, the machine in Uganda used 2D simulation. So, but I will say that came up, the question of sort of technical capacity and quality came up when we were establishing these guidelines. We were trying to use older data that was more relevant to the resources that are available currently in country. So for example, we used data that predated IMRT, and we used data that predated trastuzumab. But that's another challenge to this work, because those the resource availability is very dynamic. And so, to try to keep up with it and revise the guidelines on an ongoing basis would be very, I think, resource intensive.
Thank you.
I realize, yeah, we don't have too much time left, but I'm just curious. It took a lot of work to develop the prioritization framework and to update it. Are you aware of other places in Africa or other resource constrained settings that have gone through similar exercises or use an explicit prioritization framework?
No, I'm not. So I found several papers from Australia, and I believe Canada, and there was one paper from the US about proton therapy. These are papers that propose different types of prioritization frameworks in the setting of long waiting lines, for example. But I am not aware of frameworks for radiotherapy. There are frameworks for hemodialysis and some other, types of limited resources. But with radiotherapy, and I'm not a radiation oncologist, obviously, the technical aspects are so different. I mean, we're trying to, get a paper submitted about this project, and that question came up, and even talking to my colleagues, they weren't aware of unpublished frameworks either. And I know so I do some work at Ocean Road, which is the National Referral Center in Dar es Salaam. And for a different study, we, collected some qualitative data where people described a different approach, which is, in order to free up beds, sometimes patients who required just a shorter course for palliation were prioritized, which is sort of the opposite approach for our setting, and it was different because we were actually sending people for, it didn't matter if they needed, just a small number of fractions or the full, 6 weeks or so.
Yeah, really. I mean, yeah, it really depends what your problem is and what parts in the care pathway are limited.
Yeah. Very complicated.
So yeah, I think we are unfortunately at time. And I don't see any more questions in the chat. So I think it makes sense to wrap up now. I'll turn it over to Scott for any closing words, but I also just wanted to thank you for a wonderful presentation. It was incredibly fascinating, and I'm sure that other members of our community who weren't able to attend today will really enjoy watching it when we post the recording. So thank you.
Thank you.
No, just thanks, Tim, for connecting us with Dr. DeBoer, and thanks, Rebecca, for speaking. And I think that it's a small world, right? I mean, we're working with Fidel, you've worked with Fidel. And I hope this, part of this is to learn about people who are doing similar work and have similar interests and hopefully collaborate in the future. So I know I'm going to probably try and keep in touch with you on some of the priority setting work. But let's hope this is the start of some good collaboration between Queen's Global Oncology and UCSF Global Cancer Program.
Oh, I would love that. It's like I said in the beginning, I'm familiar with you guys and many of the people there, and so it's really an honor to connect. Thank you, and thanks Tim for making it happen.
Yeah, thanks so much.
Glad.
And really congratulations on such great work. Really amazing.
Thank you. Thank you.